Good morning, everyone. Good afternoon, good evening, maybe good night for some people. Thank you all for joining us. Welcome to the Round Glass India Center webinar series on the Trump administration's policies and how they're impacting India and Indian Americans. While President Trump's policies are affecting almost everyone in the United States, as well as globally, we are one of the few organizations and centers that are focusing specifically on India and Indian Americans, applying a lens that I think is important and unique. My name is Sheetal Kalantri, and I'm the Associate Dean Professor of Law at Seattle University, as well as the founding director of the Round Glass India Center. We're an interdisciplinary academic center focused on the study of contemporary India and Indian Americans. The center educates our communities on issues impacting us using evidence-based information and cutting-edge scholarly research. We connect India to the US by creating opportunities for cross-cultural learning and exchange to promote cooperation and develop culturally competent students. We give back by working to promote economic equality and justice in both India and the United States. As part of our mission to bring relevant information to our communities, this webinar explores the topic of South Asian health, research, and rights. Previously, we spoke of immigration, and upcoming, we have a webinar on affirmative action and universities, as well as India foreign policy. Today, I'm so honored to be joined by three nationally renowned experts. I will briefly introduce them and invite each one of them to give brief remarks and open it up to Q&A after that. Dr. Gupta is a national leader in public health and has been described as one of the nation's most recognizable medical experts. Vin is a practicing pulmonologist who currently serves as the medical analyst for NBC News and MSNBC. He is a familiar household face to many of you. He's recently become managing director of healthcare at Manny Phillips and Phelps, which is a multiple services law firm and health services organization. He's also a major in the United States Air Force Medical Reserve Corps. He received his bachelor's degree from Princeton, an MD from Columbia, and a master's degree from the University of Cambridge, as well as an MPA from Harvard. He was a Fulbright scholar and completed his medical training at Harvard, in case there were not enough Ivy Leagues in there. Samira Khan is president of the South Asian Public Health Association. The mission of South Asian Public Health Association is to promote the health and well-being of South Asian communities in the United States through advocacy, collaboration, and communication. She's the Assistant Director of Research and Clinical Initiatives in the Division of Pulmonary Care, Critical Care, and Sleep Medicine at Mount Sinai. In addition to all of these hats, she's also simultaneously continuing her role as research manager for Dr. Shah's lab, where she oversees research operations, grant applications, and project development. She received her MPA from Hofstra University. Professor Seema Mohapatra is a leading expert in health law and bioethics. She is the MD Anderson Foundation Endowed Professor in Health at Southern Methodist University Dedman School of Law. Professor Mohapatra's research centers around healthcare equity and the intersection of biosciences and the law, assisted reproduction, surrogacy, and reproductive justice. Her work has been published in various top law reviews and a number of peer-reviewed journals. She's also a frequent national speaker and is often consulted in media about various bioethic topics. She's someone I've known for over a decade, and I've had the pleasure of following her as soon as the Dobbs decision came on the New York Times, Bloomberg News, and etc. She has her JD from Northwestern and also a master's in public health from Yale and a bachelor's from Johns Hopkins. So I'm going to start this with giving each of our panelists 10 minutes to generally speak on topics relating to health and its impact on India and Indian Americans, and then open it up to Q&A. First, I'd like to start with Dr. Gupta, who will just focus on kind of what is happening, overall health concerns, public misinformation, and how to combat it. So take it over, Dr. Gupta.
Absolutely. And I'm gonna, as I'm chatting, I'm gonna go ahead and share my screen. It's great to be here. Thank you so much for that, for the invitation, the kind introduction. Uh, Sheetal, it's great to be here with such a distinguished group of panelists, and thank you everybody for taking a few minutes out of your day to just be with us on what I think is, especially on the healthcare side, I think, an extremely evolving. I'd say, we use the word unprecedented a lot. It's pretty darn unprecedented what's happening. I can't keep up with the news cycle. Big news item just this morning about what's happening at HHS, and so there's a lot to cover, and we won't be able to do it justice in just about 10 minutes. But everything that I'm going to talk about when it comes to health concerns that we've seen just in the last 60 days, I think a lot of this, frankly, was not predicted. Just the degree of disruption and what we're seeing when it comes to the hollowing out of the CDC. Perhaps some were predicting it. I don't think I saw this magnitude of disruption, frankly, that we're seeing now play out. And so, lots to cover. I'm going to talk about two main topics here in the time I have directly with you, and then would love to continue the conversation in the Q&A. One is, we can't have a conversation on the first 60 days of the Trump administration and his healthcare priorities if we don't talk about health information, accountability, independence of our federal agencies when it comes to disseminating knowledge and information, and the impact that's having not just on the South Asian community, but frankly on every single community across the country, across the world. I'm very close with colleagues over at the WHO, and I think it needs to be said that fundamental meetings that never were canceled during, say, the transition from Bill Clinton to George W. Bush, like the FDA's advisory meeting on determining the optimal design of next season's or next fall's flu vaccine. Those types of meetings you never were canceled or even delayed in prior transitions from a Democratic president to a Republican president. And so we're seeing things that are happening that are very much in line with the ethos and the thinking of RFK Jr., our new HHS secretary. Make no mistake, there's a direct line between what he's been talking about for over 2 decades when it comes to his cynicism and skepticism on vaccine science and some of these early decisions. There is a direct line. So we're going to talk about health information, and then I'd like to riff a little bit on just regulation and what that could mean. Both, the optimistic view on a deregulatory environment for healthcare. I do think that there's some benefits to smart deregulation, but then there's also a lot of concerns, of course. So it's sort of a glass half full, glass half empty discussion. But kicking it off when it comes to health information, something that I spent a lot of time as mentioned in the tee up, doing health information. I wasn't expecting to be doing this, especially from the Pacific Northwest, but I've realized just in my time as a pulmonologist, as a clinician, wearing a few hats, that maybe there's nothing more important that one can do beyond the bedside than try to reach people with trusted health information. And here's the landscape. If we take a step back, in the upper left-hand corner of this slide, you'll see what we're wrestling with. And for those that are, I recommend not doing this, but for those that have their minute-to-minute pulse on the news, nothing that I'm showing you from the Kaiser Family Foundation in terms of vaccine science, vaccine misinformation, lay comprehension of basic facts across the general public. All these issues here are converging to a lot of confusion, a lot of misperceptions on basic things like, does the measles, mumps, rubella vaccine, in this case, has it been proven to cause autism in children? This was a question that was asked 2 years ago by Kaiser Family Foundation in the midst of the pandemic. Basically, what 75% of the country says, 63% of the country says probably true, or definitely true. No, I'm not doing my math right. Probably true or definitely true. So, it is rather 32%. I'm testing my arithmetic here in real time. 32% know that's definitely false. Everybody else either doesn't know if it's definitely false or think it's potentially true. That's shocking. And when I think about the ways in which we talk about health information, I now have a chance to work with Biden CDC Director Dr. Mandy Cohen in my new role. And her and I have been talking about the ways in which, whether it's a Democratic president or whether it's a Republican president, the reality here is the way we communicate has never worked. I'd say in the last 10 years plus, it's very paternalistic. It's very, hey, let me post something on the CDC website, say here on flu, and then assume that it's going to diffuse down to people and that they're going to actually go to this website and get information. There is a reason the CDC and the FDA and all these other health agencies are so easy to mischaracterize and to create this false narrative that they're, maybe doing somehow things that are not in the interest and welfare of patients across the country. There is a reason why these agencies are not nimble in the setting of a crisis like COVID. One could argue even the setting of these sort of early stages of bird flu, because the way they communicate is top down. They post something on the website. They have essentially no meaningful digital presence, and they expect that this information will disseminate, and it just does not. So it's no surprise to me that we're seeing these broader trends here, as elicited by Kaiser Family, on the fact that most people cannot say in the country definitively that the MMR vaccine doesn't cause autism. 70+% of people, or nearly 70+% cannot definitively say that's false. And we wonder why now we're in the midst of one of the largest outbreaks. I mean, it's not even April, and we've already exceeded case counts here in 2025 and for measles across the country relative to what we've seen over the last 4 years. There's a direct line in terms of how we communicate. I put this on here, the second slide. It looks like am I already coming up for my time? I'll try to wrap up in a few minutes. We need to think about a different way to communicate. And I think our health agencies, our academic centers historically have tended to view social media, legacy media, like TV, where I spent a lot of my time, and they've judged it. And they've said, well, that's not time well spent. We shouldn't be spending our time doing things. It's not a good use of time to be posting on social, or leveraging TikTok is beneath us. And I show this to you because 1.5 million people have seen the seminal paper in the New England Journal of Medicine on COVID-19. Seems like a lot of page views. I posted here in the upper right-hand corner, you'll see a picture of lungs with COVID and without COVID. And within a few days, that got 5 million engagements. Within just a few days, 5 million engagements. How we consume health information, any type of information, but especially health information, is fundamentally changing. And I would say that the misinformers and the individuals that do not have South Asian health as a priority, or the health of the American public as a priority, that have other ulterior motives, are winning the battle in digital. I mean, look at this. This is just in the last 2 days. Fake CDC vaccine site linked to anti-vax nonprofit once headed by RFK. What was the plan behind this fake CDC website? Obviously Elon and what he's doing with Twitter, which is the biggest source of misinformation, where a lot of these battles are playing out, where frankly academic medical centers, where people with platforms do not have a fraction of the following and a fraction of the voice versus those that are looking to misinform, we're losing this battle. There's only so much. There's only so many people going to the website, the CDC website, for good information. It's not working. And I'll say, I mean, these headlines here, I mean, this is having real impacts with people. You might have seen that RFK Jr.'s former nonprofit, the Child's Health Defense, has actually interviewed the family that lost that child due to measles in West Texas. That family gave one interview. It was to RFK's former nonprofit that he resigned from to take his new posting. And what do they say? They say that they thought that the vaccine was the cause of the outbreak, that somehow it was causing infection in people and was the reason why their child sadly died. I mean, and they're getting that directly from the organization that was founded by our current HHS secretary, which, by the way, that same organization is putting up a fake CDC website that RFK himself had to find. I mean, thank God he did this. Say, no, you have to take that down. I mean, this is no joke. And so I will say, and just in closing, as I think about just the health information piece, and I'll say a quick word on regulation. I mean, we're having to do things in public media that we have never had to do under prior Republican administrations. Don't take vitamin A and think that that's going to be somehow a balm for measles or cod liver oil. I mean, these are the things. I mean, it's an absurdity. My colleagues at WHO, when they see what's happening here, it's beyond. I mean, you can't even laugh at it anymore or roll your eyes anymore at it. We're in a different, unprecedented territory. And I actually think going on and just saying, well, RFK is a moron, he doesn't know what he's talking about, is not effective. You're not going to reach those that are actually believing this. We have to provide context that there is a role for vitamin A in the treatment, or and I use the word treatment very carefully, in the management of a child who might have severe measles, that it is an adjunct to therapy. It has its purpose. But by the way, it's not really useful for most of the American population because we're not vitamin A deficient. Where this is useful is in places like Africa and parts of Asia, where there is a lot of vitamin A deficiency, which, by the way, the programs that USAID funded to help with vitamin A repletion in those parts of the world have been ended under DOGE and everything that we're seeing play out in the first 60 days of the Trump administration. So the irony here is that their talk track is diet and healthy, vitamin intake protects against measles and will save you. And where that might actually be useful, most useful, vitamin A repletion, we've actually ended funding to support those programs. So there's a deep irony here if you care to look with any level of thought and detail. Real quick, as I wrap up, there's a lot of problems here across the country that we're being distracted by these shiny objects that are sexy to talk about in media. Obviously, the train of media is whatever is controversial is going to get the headline. We're going to talk about it. This is true in the South Asian community as it is across much of the broader U.S. health community. We're affected by silent killers that we don't know about. Most 60 million adult Americans have uncontrolled hypertension, and they don't realize they have it until they end up in my ICU or in any of our, my colleagues' ICUs across the country with a stroke or a heart attack. This obviously disproportionately impacts, in relative terms, South Asian Americans. Absolutely, most people don't. Plurality of them, or a near majority of Americans don't know they have high cholesterol. That's a problem. And hey, by the way, if we're not having adequate, trusted health information from our highest levels, providing helpful awareness on these things, it's going to compound what I think is already a pretty burning crisis. I just wanted to put this out there for those that are looking for ways. This is not all doom and gloom. I do think there's ways to reach people digitally through. We're trying to do it through scaled messaging, trusted messenger based webinars. We just did this amazing national town hall that was incredibly well attended with the American Federation of Teachers and the American Academy of Pediatrics on Monday. Thousands of people were on the call, hundreds of questions, incredible engagement. I'm a believer that we have to fill the white space here, that there's things that we can actually do through meaningful advocacy to scale a better message. That I think a lot of people do not want this, and a lot of people want a third way. So I do want to end on a note of hope that there are different things that are happening right now. Happy to talk about, beyond the 10 minutes I have here on what those specifically are, but I appreciate this time and I'll kick it back to Sheetal, please. Thank you.
I invite Samira to give her brief presentation, and thank you so much, Vin.
Great. Thank you, Vin, for highlighting the current landscape of health info and just how to combat public health misinformation. And thank you, Sheetal, and the Round Glass India Center for creating this space for this important conversation. I'm honored to represent the South Asian Public Health Association, also known as SAFA, today to talk about the state of South Asian health in the U.S., the challenges showing up with the new administration and its direct effect on our communities, and what we're doing and must continue to do to advocate for equitable community-centered health. So as most of you might know, South Asians are one of the fastest growing ethnic groups in the US, yet we continue to be underrepresented in national health policy, data, and care systems. And now 3 months into a second Trump administration, we're already seeing early signals that could deepen existing disparities and erode key protections for our communities. So I wanted to just start, by highlighting some of the unique issues that are facing our communities, and focusing on some of the big key health challenges that we've seen in the work that we're doing at SAFA, and also through some of the national conversations that have been happening. And a lot of these are, continue to remain hidden by data aggregation in national policy and public discourse. So starting off, one of the most well-documented and yet under-addressed health disparities is, what Vin was alluding to, is our elevated risk for cardiovascular disease and type 2 diabetes. So South Asians have up to 4 times higher risk of heart disease and type 2 diabetes, but often at younger ages and lower BMIs, especially compared to other groups. And this isn't just linked to, lifestyle diseases. They're also deeply rooted in genetics, environmental stressors, and then systemic inequities. But also, preventative screening guidelines and risk models don't really reflect these elevated risks. And research has historically excluded disaggregated data on South Asian subgroups. Usually you'll find something on, either lumped in underneath Asian American, or you'll have Asian Indian, but you're really ignoring all the different subgroups that fall underneath that. And so we don't have a very clear picture about how this shows up in our communities. But this is also one of the areas that has been making, there's been a lot of inroads by researchers, and also at the policy level, with a South Asian heart health bill that's been kind of explored to be pushed to find more funding for research. And now shifting to another growing crisis is mental health. So depression, anxiety, and suicide ideation are becoming increasingly common in South Asian communities, specifically amongst the youth, elders, and then also first-generation immigrants. We also see that South Asians have a tendency to express psychological distress through physical symptoms, which makes diagnosis and treatment even more challenging. And then cultural stigma, provider bias, and then also a lack of linguistically or religiously responsive care often leaves these issues unaddressed. We find that a lot of South Asians don't have the correct vocabulary to address what they're going through. And then the vocabulary that's being used by researchers and clinicians doesn't really capture. And so you're going to have a lot of just underdiagnosed people that are suffering from some of these issues. And then next, I want to acknowledge a group within our community that's often rendered invisible in all of these conversations, which is the LGBTQIA+ South Asians. So queer and trans South Asians face a multi-layered discrimination from within and outside the community, including homophobia, racism, xenophobia, and familial rejection, already placing them at a disadvantage. With threats to gender affirming care, LGBTQ+ family rights, and then non-discrimination policies, they heighten a lot of these health vulnerabilities, and then it leads to a risk of poor health outcomes, potential of homelessness, and then mental distress. And this continues to be exacerbated in the current climate. And then lastly, I want to emphasize a factor that really cross-cuts across all of these different health issues: the role of racialized state violence and structural discrimination in shaping South Asian health, which is another key but often overlooked driver of poor health outcomes in our communities. So a paper that SAFA had published a couple of years ago highlights really the long history of racialized violence against South Asians, especially those that are racialized as brown, including Muslims, Sikhs, Dalits, and immigrants. Since 9/11, these groups have experienced an increase in surveillance, profiling, and criminalization, often under laws that are framed as security or immigration enforcement. But these are not just civil rights issues, they are also public health issues. Chronic stress, fear of deportation, institutional distrust, and intergenerational traumas all have measurable impacts on the physical and mental health. And it also leads to distrust in institutions, which leads to lower care utilization. And today, again, we're witnessing a lot of visa revocations, detentions, intimidations of dissenters, really echoing patterns of state violence that have profound health consequences. And if we fail to name these harms, we also fail to address the full spectrum of what keeps South Asian communities from accessing and benefiting from care. So now, how are these issues being influenced by recent policy directions from the current administration, specifically within the South Asian community? So, as Ben had alluded, in just the past 3 months, we've seen a lot of policy shift that raises concern for public health. Definitely with the misinformation space, but also in terms of research, transparency, and global cooperation. So just to go over a couple of those things that we've been seeing and keeping an eye on. The first is cuts to NIH funding and research infrastructure. So proposed NIH and CDC budget cuts would really undermine the research we've tried to make progress in on aging, diabetes, mental health, chronic disease, including projects that SAFA has been involved with. And we've already struggled with getting that disaggregated data and understanding what this looks like in the South Asian community and South Asian subgroups. But the fact that we are now losing out on research and research infrastructure, this problem is probably going to be announced a lot more, right? We could lose access to a lot of the disaggregated data that we already have and a lot of the inroad and progress that we've made in collecting that. And as we know, when our communities are excluded from research, they're also excluded from interventions and funding that can follow to help enhance some of this. Next, we have threats to Medicaid and the Affordable Care Act. So there are renewed calls to cut Medicaid, roll back ACA protections, but something that's not really discussed is that over a quarter of Asian Americans rely on Medicaid and ACA and public health insurance. And so for many South Asians, particularly immigrants, elders, low-wage workers, these programs really are their only access to care. And so by enforcing more work requirements, eligibility restrictions, or immigrant exclusions, this would really widen the disparities, it would delay diagnoses, and it would really increase the uninsurance rate. That's something our community is already really struggling with. Shifting over back to just science and research, there's a lot of efforts to undermine scientific transparency. So we're seeing efforts to remove health information from federal websites, including content on reproductive health, on vaccines, climate-related illness. And so we already have issues with navigating language and digital literacy barriers. So this is really just going to enhance that. And then finally, cuts to global health programs. To USAID and other programs, it really jeopardizes care systems abroad that the diaspora has connections to. And so it also reduces the US readiness for future pandemics, climate-driven mitigation, and international public health cooperation. So now in the last 2 minutes that I have left, I really want to just focus on what can be done, what we've already been doing. And so I wanted to just quickly share our website. SAFA has been making inroads in really trying to make access available to a lot of this information. And so on our website, we have resources and toolkits on how to, right now, on cardiovascular and diabetes, on interpersonal violence, but we also plan to include things on cancer, mental health, etc. And this really gives you access to the current research on what you can do to advocate for change, patient advocacy, resources and facts on different diseases that affect South Asians. And then also our publications. We've also developed a research hub, which I've pulled up here, which is essentially similar to a South Asian PubMed. And so this really helps to highlight the research that's been done in South Asian communities, and you can filter on different terms and publication types. And then we've also compiled a database or a table of all the publicly facing databases that does still include some disaggregated data. And we're hoping that researchers can use this to find specific data for the community to help advocate and to more research in these areas. And so, it's really imperative that the community continues to utilize these resources, continues to advocate for our community, and really focus on enhancing public health literacy through taking research and then translating it to the communities. And really, that's something that we are also trying to do through our webinars and some of our social media posts. And then lastly, we're just trying to really up the representation of South Asian public health professionals and bring together a network of people who are passionate about this cause and are passionate about taking this work to the next level and really advocating for South Asians at a public level. And so just to close, South Asian health really, it's not just about medicine, it's about systems, policies, and powers. And we have to really invest in culturally responsive care, research inclusion, and then protection across the different levels of our institutions so that South Asians can live healthy, dignified lives. And so it's really essential that we continue to do this work, especially in the face of these challenges. So thank you. I'll hand it over now to Seema.
Thanks so much. Thank you, Samira and Vin, for those great remarks. I also wanted to thank Sheetal Kalantri for inviting me to speak today, and to Shannon Young for coordinating all the arrangements. And I wanted to make sure you guys can hear me, right? And
Yes.
I think I have a PowerPoint that's going to be shared. All right, I'll start. In my 10 minutes, what I'm going to do is discuss abortion rights and access in the United States under the Trump administration. And I'll also highlight how restrictive abortion-related laws disproportionately impact marginalized communities, such as South Asian women, and explore broader issues of reproductive justice. So if we could go to the next slide too. So nearly half a century after Roe versus Wade was decided in 2022, the Supreme Court decided Dobbs versus Jackson Women's Health Organization, which overturned a critical legal precedent and took away a fundamental right that generations of Americans had relied upon. This decision was able to be made due to the conservative majority on the Supreme Court, including the 3 Supreme Court justices that President Trump appointed in his first term. And so next slide, 3. Now in 2025, access to reproductive health care largely depends on where you live. At least 14 states have banned abortion outright, and with only minimal exceptions, and several others have strict limits, often around 6 weeks, well before most people know that they're pregnant. And so this patchwork of laws forces countless individuals into these impossible choices, traveling hundreds of miles, spending money they don't have, or simply going without critical care. And of course, you know, as Samira mentioned, these burdens hit hardest those who face systemic obstacles. And so low-income communities, people of color, and immigrants. And so Dobbs sparked an unprecedented wave of restrictive state laws. And so there's entire regions of our country, such as in the South and Midwest, that are abortion deserts. And so even though the number of abortions in states where it's legal has risen actually by 11%, behind that statistics are thousands who manage to overcome significant barriers. For each person who finds a way to obtain care, many others can't navigate the logistics or costs involved. And so the fallout also from Dobbs doesn't end at abortion. Lawmakers are already targeting other reproductive health services such as contraception and IVF. Next slide. Let's consider, if we consider who this impacts most severely, and this kind of relates to the topic of this webinar, women of color have always faced significant hurdles accessing healthcare. And now with abortion bans sweeping the country, these barriers have just intensified. Women of color are more likely to lack insurance, have lower incomes, face barriers such as language and immigration status. And so these factors obviously make travel to obtain abortion care more than just inconvenient. It's almost impossible. And forced pregnancies further deepen poverty and vulnerability and reinforce cycles of inequality and hardship. Next slide. And so these laws have also led to some deeply troubling criminalization of pregnancy outcomes, which is sadly something that isn't new. This happened pre-Dobbs and will likely get worse after. On the slide, I have 3 women who were targeted. Purvi Patel, an Indian American woman from Indiana, she experienced a miscarriage and she faced criminal charges under the feticide laws, and prosecutors accused her of self-inducing an abortion, and she was initially sentenced to 20 years in prison. Her conviction was eventually overturned, but the chilling message was clear. There was a similarly alarming case in the experience of Bebe Schwa, who was a Chinese immigrant, also in Indiana, who was charged with murder after losing a pregnancy due to a suicide attempt. And then Marsha Jones, a Black woman in Alabama, was indicted for manslaughter after being shot and miscarrying, criminalizing her for circumstances beyond her control. All of these cases were pre-Dobbs, but with the enforcement of anti-abortion laws, we can expect even more criminalization to occur. Next slide. So South Asian women, including Indian Americans, face particularly complex challenges in this new landscape. There's cultural stigma around abortion and pregnancy loss that can be isolating, making it difficult to seek help or even openly speak about these experiences. And now with fear of legal repercussions, especially for immigrant women, that adds another layer of risk. And language barriers, misunderstandings about cultural practices also complicate access access to healthcare. Even women considered low risk in medical terms, South Asian women face disproportionately high rates of complications such as gestational diabetes, preeclampsia, and postpartum hypertension, which can affect their health long term. And often the healthcare system, as we've heard from our first two speakers, often overlooks South Asians and South Asian women's unique needs, which leaves them vulnerable and underserved. Next slide. So the immigration status also makes these situations even more precarious. In states with strict abortion laws, if there's interactions with the healthcare or legal system due to pregnancy complications, that can inadvertently expose non-citizen women to immigration enforcement, which deters many from seeking essential care. That fear of deportation or legal trouble is an enormous barrier that causes significant health risks. These stories are not isolated incidents. They highlight a troubling pattern. Pregnancy has increasingly become a target for surveillance and punishment, driven by the dangerous ideology that prioritizes fetal rights over a woman's rights and well-being. And so this criminalization especially harms marginalized communities, which creates a dangerous precedent for women's bodies becoming a political battlefield. Next slide. I'm kind of running out of time, so I'll just show the slide, but there's a study known as the Turnway study that shows the deep economic and health consequences of forced births, and those are well documented. Next slide. And Dobbs has also impacted broader healthcare services because abortion procedures and miscarriage treatments are medically similar. Doctors in restrictive states now hesitate to treat miscarriages promptly and fearing legal repercussions. And contraception and fertility treatments like IVF are also under threat as lawmakers continue to blur lines and create confusion intentionally. Next slide. We also can't, Samira mentioned this, but we can't ignore the mental health toll on South Asians that these laws impose. And so there's uncertainty and fear surrounding pregnancy and healthcare access that adds tremendous stress, increasing anxiety and depression. And so for communities like South Asians that already face stigma around mental health, this added pressure can significantly impact their well-being. And so we need healthcare providers to have training to address these mental health concerns. Next slide. I just wanted to briefly also mention that President Trump also enacted sweeping changes to reproductive rights abroad. He reinstated the Mexico City policy, which is also known as the global gag rule, which cuts off U.S. funding to international health organizations that even mention abortion. So that affects millions worldwide. And there have been additional efforts in this administration since January to cut off global aid in general. Next slide. So an area of advocacy, a crucial area for advocacy is public education. Many people remain unaware about how drastically abortion laws have changed and how those changes affect their rights. So we need to have clear, accessible information in multiple languages, especially for immigrant communities. And education can empower people to make informed decisions, reducing fear and misinformation that often spread in the absence of reliable resources. Next slide. And we also need community networks to support those that are most impacted by these restrictive laws, and grassroots organizations and also community leaders like Samira's are great in providing resources, support, and advocacy. Next slide. And so, another thing is that healthcare providers should have culturally sensitive, language accessible care, and we need to address racism and microaggressions within healthcare directly. And these kind of strong community-based networks are essential in providing support to South Asian women and their families. Next slide. And I'm just going to end here. I have a picture there of Savita Halampavanar, who is a South Asian woman living in Ireland who died needlessly after being denied a life-saving abortion, and her story ignited change in Ireland. And I put that into terms of, I hope that we don't have to suffer those kinds of examples in order to have better care in general for women in the United States, including South Asian women. Next slide, I'll just thank you guys for giving me this time, and that's my contact information.
Thank you so much, Seema, and to all the panelists, Vin, Samira. Really appreciated your comments and thoughts and overview of what's happening today. I particularly like that you presented the challenges as well as some paths forwards and solutions. I'm going to ask a question to each of you while I invite our audience members to submit their questions in the Q&A button in below the screen. It's a question mark on it, so maybe you can find it and you submit. Go ahead and submit your questions, and we'll turn to those shortly in the brief time we have left. So for Vin, your point was the disinformation that's surrounding health. Of course, it's surrounding every piece of news that we face, but I want to focus specifically on kind of how that hits maybe South Asians or Indians. I know that if you have potentially grown up in an Indian household, you've all drank turmeric and warm milk when any ailment occurs to you. So we're very much into alternative Ayurvedic medicines, and it's worked for many, right, ancient traditions to have that before allopathic medicine was discovered. So how do we address those challenges, or how do you see those challenges playing out in specifically Indian South Asian communities?
Well, I think this is where thank you for the question, and I loved my co-panelists, all your comments. So thank you again. This has just been a great morning. This is where I'm hopeful that there's hopefully a silver lining to the deregulatory environment, or a sort of a refresh view on what we regulate, what we don't. And maybe there's a positive silver lining that comes from RFK Jr.'s stint at the very top. And what do I mean by that? You mentioned turmeric and warm milk and sort of alternative therapies. And I do think they have their place. And the problem is, for an allopathic doc like myself, we're not trained at all to speak about any of these therapies or supplements or sort of alternative remedies with any evidence base, because it's not studied. It's not regulated. And so, I reference deregulation because that seems like that's the trope of the Trump administration. I think smart revisiting of say FDA guidelines on medical devices, and how I do think that there's stringent criteria for certain medical devices to come online for, say, screening of high blood pressure, that sometimes impairs innovation from reaching people's hands quickly because we just have such a high bar. Different topic. So maybe smart deregulation there could be useful. In this case, I think RFK saying, hey, listen, I talk so much about alternative remedies. He's so against sort of proven science. Maybe we should actually start to have a regulate or a safety and quality regime on supplements. More people take supplements, vitamins, than they take prescription medications across the country. You'd think it's time to have some sense of what's working, what isn't, what's sort of quackery, what's real, so that we can talk about this in real, meaningful ways. And the fact that there really isn't that federal presence, quality, safety, NIH-funded studies. I mean, of course, that's probably unlikely in the next 4 years. There's a huge gap there, and I think it would actually really align with his priorities. So that's where I'm hopeful the glass is half full, and perhaps we can talk about this with a little bit more rigor, should he be willing to go there.
Thank you. I really appreciate that bringing in the ideas of alternative medication and prevention is, I think, everyone can get on board with. Samira, thank you for your comments. And I particularly want to just highlight, you, I think, mentioned USAID as something that will impact India. Some of the data, and I know I, again, don't know if this is accurate or not, but I've seen that India potentially gets $200 million a year from USAID. So it is going to be a significant impact on the health outcomes of many people around India. So that is worth saying as we think about how how our policies are shaping the world. The specific question I want to ask you, and I think this is maybe just draws out a little bit of what you've said. Many people maybe aren't familiar or don't know, but it would be helpful if you could just highlight the why we need disaggregated data on South Asians and what are the specific health challenges that South Asians face compared to other communities.
Yeah, thank you. That's a great question. Disaggregated data is something that we've been fighting for so many years. And one of the reasons is, when you look at national data sets, when you look at research, oftentimes, or most of the time, South Asians are lumped underneath Asian American. And so what that really does is, you have over 100 different ethnicities that are now categorized in that one bucket. And we are not a monolith, right? Even if you look at the South Asian subgroups, Indians, Pakistanis, Bangladeshis, we're all very different. The social determinants of health that really influences our health outcomes. And so when we're now being lumped underneath a category of Asian American, it really just minimizes the risks that are unique to our communities. And it aggregates all of that. And so it might show up as, Asian Americans are really healthy, but that's not the case. And so I think just going back to, cardiovascular and diabetes. And so one thing that we know is that South Asians are, have a higher predisposition to developing diabetes at a much earlier age, and also at a lower BMI than is in, the guidelines. And so there was an initiative called Screen at 23, which really pushed for doctors to start, checking for diabetes in South Asian communities at that BMI, which is not something that, other ethnicities are, experiencing. Their BMI, their diabetes predisposition doesn't show up until much later. And so when we have disaggregated data, we are then able to really highlight the nuances and then push for, more culturally responsive care, but also really tailor some of these recommendations to the different ethnicities and South Asians in particular.
Great, thank you. So for Seema, one kind of general question and observation is just sort of the way in which, post-obs, there continues to exist sort of different ways in which states are addressing abortion, right? Some very open and liberal and continuing as business as usual, some closing it down. I think, thought or worried, right, in the sort of reproductive rights scholarly community, which you and I intersect on, is that the Trump administration would come in and use its powers to try to clamp down on states like where I live, Washington State, and say, using federal powers and certain federal law, for example, that prevents commercial movement of certain goods that are used for abortion healthcare. We haven't seen a ton of that, right? And which is worth noting and highlighting, of course, and what love your feedback on that. And then the specific question on and South Asian health I wanted to ask you is, you mentioned all these stories of women who were targeted from Indian and South Asian backgrounds in Ireland and US who face criminal sentences, who were having late abortions. Why is that? Is that societal context within those communities? Is it external racism? Is it the laws? Is it health indicators for those groups? So thank you.
Great. Thank you for those questions. Yes, so you're absolutely right that in terms of the potential of what federal laws could do in terms of, like a national fetal personhood, kind of provision that would basically make abortion in every state illegal, right? That hasn't been proposed. There's executive orders that mention in the Trump administration that mention fetal personhood, but there's not, there hasn't been any kind of legislation or effort on that regard. And I think part of it is that abortion in the United States is still supported by the majority of people, even in states that have anti-abortion policies. And so I think part of it is, there hasn't been an interest, and even in states that have kind of tried to target IVF or things that are more popular, that has not, there have been physicians that say they're going to leave those states. In terms of the federal, the most worrisome thing right now would be medication abortion and restriction on medication abortion, which is the most commonly used form of abortion. And that's restriction of the abortion pills, either through the FDA, HHS, and the Biden administration had some policies, executive orders that said they would not kind of enforce these interstate rules. Right now, we haven't seen any kind of action on that regard. Now, in terms of your second question about, why do we have South Asian populations or examples of people that have these extreme situations? I mean, I think that you mentioned a lot of things, and I think it's yes to all of them, right? Whether it's the lack of access to healthcare, the stigma within the community, the fear of legal repercussions, the kind of stigma of whether it's unintended pregnancy or even having complications with your health. And I think part of what Samira's organization is doing, and what Vin was talking about in terms of just getting the education piece out there, I think that's really important to kind of have women be able to advocate regardless of their immigration status, their language ability, and whatever support or not support they might have.
Great. Thank you. So we have, I guess, just a comment from an attendee that South Asians with heart disease, we should use a preventative model using multidisciplinary team approaches to the care. I wanted to give each of you just a couple of minutes if you wanted to make some concluding remarks or tie up themes, and then I will close it out with some thank yous. So any one of you, if you want to say something, Vin, Seema, Samira, you're welcome to. We have a couple of minutes.
I'll kick it to my colleagues first, please.
Or you feel I didn't give you enough time, because we were very tight with our 10 minutes with you. So if there's anything that you wanted to add.
I think that the talks all mesh together really well. And I'm really glad that the Round Glass India Center kind of decided to host this, because this is often an area that's not discussed. We have South Asians and Indians that are overrepresented compared to the population in the medical field, but we still have these healthcare disparities that are often ignored. So I'm really happy to be part of helping educate people about these.
I wanted to just echo what Seema and Ben had been talking about. I think just given all of our presentations, it really highlights that, and the comment that was in the chat, that a multidisciplinary approach is really necessary in the upcoming years. Just really bridging together public health, healthcare professionals, law advocates, to really help to address these issues coming up in our communities, but also to come together to find solutions, and really carry out that health education campaign and the narrative, and take control of the narrative. I think is going to be very important, just given all of the challenges that we might be foreseeing ahead. And it's just really grateful to have the space to come together and highlight all of that as well.
Yeah. Well, I just want to express gratitude. Just incredible panelists, and your work is truly admirable. I'm hoping that this is just the first of our engagements. And to the Round Glass Center, Sheetal and Shannon, thank you for organizing. I mean, what I would say is I do sometimes feel like people think that we're speaking into the void when we're talking about these issues, or well, gosh, isn't it obvious that the measles, mumps, I keep talking about that because that's sort of top of mind when we did all this content this week on that topic. And then aren't these things self-evident? Isn't this obvious? And is there any point in even talking about it? And then I think about some of the direct engagements we did during the pandemic, on things that were controversial, like the vaccine, or just the questions we got this week on this national town hall on the epidemic. And you start to realize that if you directly engage people, you try to do it in a way that scales the message, but you're willing to hear their opinion. And I know seems like a sort of tired trope. Let's just hear them out and try to engage. But at least in health, I'm always reminded, and it keeps me humble, that, gosh, a lot of this stuff isn't obvious. There's a lot of misunderstandings that can be corrected. And yes, you're not going to reach everybody, that's for sure. So if success looks like, gosh, we got to convince 10 out of 10 people in every room to think our way, that's never going to be the case. But I think if we can turn 2 or 3, or at least correct a misperception, because there's so much nonsense out there, that's successful. And that's a great definition of success. And I saw a lot of that play out just this week. So to me, it's understanding, what are you trying to do? What are achievable goals? Not letting perfect be the enemy of the good. And then also recognizing there's a lot of value to some of this engagement, not to feel hopeless. And I get constantly reminded of that whenever I try to do it in ways that are both familiar, like media, or perhaps something that's a little bit newer, which is digital ways to reach people. So anyway, I really appreciate this conversation and just what we're all trying to do together. So thank you.
Thank you for all you guys do. And I appreciate your time that you've taken, and as well as the audience members. We've got, like, joining our panels, joining our audience members are 30 U.S. states represented, 20 countries. I think there's real interest in shining the light on in a community that doesn't necessarily get as much representation as we should. I also want to thank the Associate Director, Shannon Young, for organizing all of this, which couldn't be done without her. We've got an amazing webinar coming up April 9th with President of Seattle University, Eduardo Peñalver, and constitutional law scholar from Cornell, Mike Dorf, one of the foremost constitutional law scholars in the country, talking about universities. Where are we? Where's the future? What's the state? And focusing specifically also on affirmative action, how this impacts India and Indian Americans. I want to thank our community sponsors, Indian American Community Services, Indian American Impact Foundation, South Asian Bar Association of Washington, South Asian Public Health Association, Traveling South Asian Literature Festival and Jaipur Literature Film Festival, or Literature Festival of Seattle, and the World Affairs Council. It's been really great to talk with you all. Thank you all for joining us. And I really hope we can convene together and make a difference in how our country moves forward. Thank you again.